Well, thanks for coming. Today we're going to just talk about total joint replacements, some of the current concepts, and what the future holds for total joint replacements. My name is Dr. Daniel Sohn. As a point of introduction, I'm from Chicago. I grew up in Chicago. I went to school there at the University of Chicago, and then I did my residency at the University of Michigan, so this is a halfway point. So I met my wife at Michigan, and we found a great community to live in, and I've been here for 20 years. And I've just had a great time here. A lot of you I know already, and and hopefully we can just give you a concept so that you can go out there and teach this to other people. In a sense, I want you to learn as much about osteoarthritis today so that instead of learning just words, you understand the concepts. So why does one thing happen? Because something else happens. I like learning in that way. That's the way I like to teach as well, okay? So we're going to talk about a general introduction to osteoarthritis. We're not going to talk about rheumatoid arthritis and things like that. We're going to talk about some of the conservative treatment modalities that are out there, and we're going to talk about surgical treatments. And we're going to talk about some of the advances in total joint replacements. I'm going to mainly talk about the hip and the knee, but of course, if you have any questions about the shoulder, I can talk about the shoulder too. And a lot of these concepts apply to the shoulder as well. So, and the anatomy of osteoarthritis. In order to understand arthritis, you have to understand certain specific terms. One is ligaments, the second is meniscus in the knee and labrum in the hip, and articular cartilage. So you see somebody who gets an ACL tear and you say they want to get their ACL fixed. Why do they need their ACLs fixed? Because the ACL is the primary stabilizer for the knee. When you don't have an ACL, you damage the meniscus. What's the meniscus? The meniscus is a cushion for the knee. So if you don't have an ACL, you damage the meniscus, and if you don't have the meniscus and you damage the meniscus, then you start damaging the articular cartilage. And I'm going to talk about why the articular cartilage is so important. So the ligaments, once again, protect the knee from shear stresses. So when the knee is put through a range of motion and also it wants to slide, the ligaments tether the joint so that it doesn't move, and it protects motion. What does the meniscus do? The meniscus are cushions. One is on the medial side of the knee and one is on the lateral side of the knee. And those two cushions help distribute the force that goes down from the femur to the tibia. As you can see, it distributes the force over a wider area. Instead of all being concentrated in one spot, it spreads out the load. Sort of like, a car with 2 wheels in the back versus 4 wheels. If it weighs the same, you'll have a lot less stress with the ones with the 4 wheels. So, the meniscus helps decrease contact stress. So if you have the same load that goes across a joint, the meniscus spreads that out. And what it does is that it increases the area of contact so the stress goes down. When you look at an MRI of the meniscus, this is what it looks like. Here's the thigh bone, here's the shin bone right down here. Everyone see that? And then this structure right there is a cross-section of the meniscus. It looks like a triangle in the back and a triangle in the front. And this is what happens when there's a tear in the meniscus. So sometimes you think, why did I get arthritis? Well, it may be genetic, of course. It could be from many different causes. But this is one route. You injure the ligaments. You injure the meniscus. And then you start developing damage to the articular cartilage. In the hip, we used to think that people who had hip arthritis just sort of had it. We look at someone's x-ray and you show up in the office and we say, well, you just have arthritis. We didn't know why. But more and more, as we understand the anatomy of the hip and the functionality of the hip, we start seeing, oh yeah, if you look at your x-rays 15, 20 years ago, you could see that there was the progenitors or the early causes of arthritis developing. So we understand the ligaments. Ligaments help stabilize the knee. The meniscus is a cushion. And then what the articular cartilage is that the meniscus protects the articular cartilage. When you look at all joints in your body, it has a bone, and then this covering over the knees, over the joint. And this covering is called the articular cartilage. It's very well affixed to the bone. And when you have this, it allows your knee to be cushioned. So what is articular cartilage? Articular cartilage sort of looks like a coconut. When you look at articular cartilage, it's white, and when it's healthy, it looks nice and sheen. But also it's like Swiss cheese. It has a matrix, and then they have these little holes inside. Under the microscope, you can see that these holes are filled up with chondrocytes. And chondrocytes are cells that help maintain the protein matrix of the cartilage. And then there is a fibrous component to articular cartilage. So this is a picture of a boat, and on a boat, it's nice and smooth. But when you get into a boat accident, or like a Corvette, when you see like a Corvette, you get into an accident, all these fibers are seen. So when it's healthy, it's nice and smooth, but when you have damage, you can see all the fibers. So this next slide here shows you what that looks like. So this is articular cartilage. It's attached to the bone. It makes up the components of all joints. There is the cellular component with these chondrocytes. There is the protein component, the type 1 collagen, and then these fibers. The fibers help hold everything together. So when you look at somebody who has a healthy looking knee, it looks like that, sort of like a coconut, you see? There's the thigh bone, there's the shin bone, there's the meniscus. And then on this picture, you can see that the cartilage is worn out and there's exposed bone. Now, why is that? Oh, so here's an x-ray. So you go to the doctor and you take an x-ray, and sometimes you'll see a knee that looks like this. This is a healthy looking knee. Why? Because you can't see cartilage on x-rays. So people always say, well, can you show me can you take out the cartilage? Can you take out the arthritis? Well, you can't take out the arthritis because arthritis is not what you have sometimes. It's what you don't have. And in this case, what you don't have is articular cartilage. When you don't have articular cartilage, you have bone-on-bone contact right there, okay? And in the hip, same thing. You have a healthy-looking hip over here on the left. On your left. The gap here is between the thigh bone and the acetabulum, and that gap is made up of articular cartilage. So when you lose it, you start seeing this. You see narrowing right there. And then when you really lose it, you've got nothing but bone-on-bone contact. So articular cartilage is protected by the meniscus and the ligaments. So one of the things that we do is that when you have torn cartilage, you can go in there and clean it out, like this. And if you're lucky enough, if it's torn in the right area, in the right spot, and in the right way, you can actually fix it like this. Okay, so why is articular cartilage so important for your joint health? And the reason is because it's neuropathic. Neuropathic means that it doesn't feel anything. You can open up someone's knee, shoulder, and you can cut the articular cartilage out with a knife, and you wouldn't feel it. Why? Because there's no nerve endings to it. Articular cartilage has no nerve endings. And that's what we're trying to do with joint replacements. We want to put in something that you don't feel, okay? So that's an important factor of articular cartilage. Number two, it acts as a cushion. How does it act as a cushion? Because it's like a sponge. I told you that there are this protein matrix in articular cartilage, there are these fibers in articular cartilage, and then these cells. If you have healthy articular cartilage, it looks like a healthy sponge. Every time you step down on your knee, the water is expelled, and every time you lift your leg up, the water gets sucked back in. So as you're walking, water is coming in and out of your articular cartilage, and it acts like a sponge. But when your articular cartilage gets old, it's like an old sponge. It doesn't suck up as much water, it doesn't expel as much water, it can't hold as much water. As you can see, as cellular damage happens, you have less and less cells and less protein material. So, articular cartilage has no pain fibers. I told you that it has no pain fibers, that's why we call it, it's neuropathic. So what happens when you lose articular cartilage in your meniscus? Well, it's sort of like, if you lose articular cartilage, it's like having no air in your tires or not having a shock absorber. You may be driving along and a small bump you drove over years and years would not have bothered you. But when you lose your air in your tires, a small bump can cause a dent in your rim, right? So in essence, this is a picture of an MRI that shows that there's damage to the articular cartilage. And in this particular case, in the thigh bone here, there's increased swelling. MRIs pick up water. So what this shows is that there is water inside the thigh bone. So there's swelling from the fact that there's been impact to it. Okay? So without articular cartilage, it's like driving around with no air in your tires. So what are the conservative methods of treatment that we offer? Number one, there's bracing. You can try braces and wraps around your knees and stuff. Weight loss is important. Exercise and physical therapy. So if you think of your knees as like a car, if you take weight off, it's like taking stuff off the back of your car if you have bad tires. That'll help the car drive better. Also, physical therapy, if you get your legs strong, that could help, because your quadriceps acts like a suspension system. By the way, if you have any questions, please stop me. Go ahead.
Yeah. What is the basic definition of arthritis?
What is the basic definition of arthritis? Osteoarthritis, the definition is that you lose articular cartilage. So when you lose articular cartilage, like I say, you lose that cushioning function, and so every step you take, it's like walking on, 2 rocks or something, okay? Anytime you guys can ask questions. I can jump around back and forth, it's easy. So, exercise and physical therapy. The other thing that's a hallmark of treatment is medication. Any kind of anti-inflammatory medications. Aspirins, ibuprofen, Aleve, Mobic. And then there's injections. If you fail all that, you can go and get an injection. The first types of injection is steroid injection. The second was viscosupplemental treatment. That's like injections like Synvisc, Hylargan, Suparts. And the third, sort of the newer thing, is PRP, platelet-rich plasma. Okay? I'll talk about those. Go ahead.
Are you going to talk about that later?
Yeah, I'll talk about that. So, steroid injection, well, I explained steroid injection. It's almost like getting an aspirin pill, grinding it up, and putting it inside your knee. It's the same type of effect. It's an anti-inflammatory effect. Yes?
How often and how long can you get those steroids?
Well, in joints, you can get them about 3-4 times a year. And the problem is the first one always works the best. And so the second one doesn't work as well as the first one, and the third one doesn't work as well as the second one. So you can get it 3-4 times a year, but most people get about 3, and then they throw in the towel. Okay? So it's like an aspirin pill that goes inside the knee, or the hip, or the shoulder. Viscosupplemental treatment. So about 15 years ago, viscosupplemental treatments came out. Hylargan, Suparts, Synvisc, you've probably seen tons of advertisements for them. Overall, there's no significant clinical benefit, and there's sometimes adverse effects. So in other words, when they first came out, the companies told us that it can help maybe 50% of patients with 50% of their pain. But as time went on, we just realized that it doesn't help patients as much. And what's happened recently, early in December, a lot of insurance companies stopped covering it. So in fact, you probably can't even get this unless you pay out of pocket depending on your insurance. So we don't do this that much anymore. In my experience, it doesn't work that well. Now every once in a while I find somebody who it works really well on, but not all the time. So then the last thing is PRP, which is platelet-rich plasma. So basically, what you do is you draw blood. You go to the doctor and you want this type of injection. So you draw blood and you spin it down. You put it in a centrifuge. And the red blood cells, which carry oxygen, settle on the bottom. The white blood cells, which do all the healing in your body, the platelet area, the white cells, settle in the middle. And then this part here is just where the plasma is. So you collect this white area here, and then you inject it into the joints. How promising is this? It's really not shown to be very promising in joints. Now, some people have had injections into their tendons. Sometimes that can have positive effects, but we've not really had a tremendous success injecting these into joints. Because what you're expecting to do is, think about this. You have a knee where there is a loss of cartilage. When you inject these white cells in, you're not going to suddenly have these white cells stick onto the bone and create new cartilage. It's not really it's not really been shown that that's what happens. That's one of the reasons why it hasn't been shown to be efficacious.
PRP is a little different than actual stem cell treatment?
It's a little different. It's more peripheral blood, yes. If you get actual stem cells, once again, this is not covered by insurance, and you got to pay out of pocket. It's pretty expensive. Actual stem cells, you're talking about your own autologous stem cells, you got to get from bone marrow. So.
But do those, because they can differentiate into osteophytes, do those sometimes work then, or that?
Well, in a sense they can. What we do is, there is, it basically is like saying, we've got a bunch of potholes on John Deere's, and you're going to fly over with a B-52 and throw down asphalt to try to cover up the potholes. That's not a concept that's going to work well. Because if you go back a couple slides, what happens is that when you look at the cartilage, there has to be a firm foundation between the cartilage and the bone. And that firm foundation hasn't been shown to develop when you inject PRP. So, think about it this way. Once again, let's go back to the coconut idea. When you have a coconut, you have the husk, and then you got the brown shell, right? And then the meat inside the coconut. There's a connection between the two, and it's sort of hard to break. And that once you break that, and you have exposed coconut, what is it? The brown thing, the brown part of the coconut. It's hard for the meat to stick back on there. You see what I'm saying? It's not very easy to get the cartilage to grow back onto that brown part of the coconut. So there is a technique by which we do regrow cartilage, but in fact what you do is you actually have to drill holes into the bone, and then you take a piece of periosteum, and this is for a very limited area. So let's say you have a part of the thigh bone that has cartilage loss. You can actually get a piece of periosteum and sew and glue, basically like a kangaroo pouch, and then you grow chondrocytes in the lab, and you give them a ton of steroids. I mean, basically a lot of growth factors, make them proliferate, and you create a little putty, and then you can inject that into those areas. And there are other companies out there that have like jellies that you can put onto discrete areas. But that's not really for our arthritis, though. I mean, basically, when you have arthritis, you have widespread damage. So what those treatments are for are very discrete areas of cartilaginous loss. So. Yes?
Would this and the stem cell, would that be kind of a precursor to something that might be coming along 5 years or more down the road?
Yeah. What you're talking about is a very sophisticated kind of idea, and that is to say, is there an interface that you can grow stem cells on and then basically put it onto the bone? There are some thoughts about working on that. People have come up with different matrices to try to get chondrocytes to grow onto them, but it's not, it's not like, you're talking about like when they grow ears on the top of mice and stuff, right? And then you use that to put back onto the knee. That's not really something that's happening right now. I think in the future, and perhaps that'd be a good, potential possibility, but it's not currently being used in human trials. Okay. Yes, sir.
What are cortisone shots?
Oh, cortisone shots. Cortisone is basically an anti-inflammatory agent, sort of like an aspirin is. You basically dissolve cortisone in a conduit, and then you inject it into any joint, and it decreases inflammation. It's like an aspirin pill that you inject inside your knee, or hip, or shoulder.
It's not a steroid?
Oh, it is a steroid. Yeah. It's aspirin. It's in the same. It's sort of in the same family as aspirin, steroids. Yeah. Cortisone. I'm sorry. Cortisone is the same family as steroids. Sorry about that. All right. Let's talk about surgical treatment. There is knee arthroscopy. There's a thing called subchondroplasty. This may be sort of a new thing, and this is. I think it looks like you guys are really into like the newest things. So I'll focus on that a little bit. There's unicompartmental knee replacement, there are total knee replacements, hip arthroscopy, and total hip replacement. So let's talk about knee arthroscopy. Now, if you have problems, let's say in your knee, and you have mechanical symptoms, but you sort of have arthritis too, if you have mechanical symptoms, you can go in there and clean out cartilage or loose bodies that can help you with your mechanical symptoms. But it's not the way to treat arthritis. It doesn't really regrow cartilage. You're not really doing much in terms of reestablishing the continuity of cartilage, articular cartilage inside someone's knee. So this is a knee arthroscopy. Someone has a tear. What kind of symptoms do they have? They have swelling, they have point tenderness. When you touch their knee, it hurts on one spot. And then when your knee moves, sometimes it'll catch. And in those situations, you can look inside, see the torn cartilage, get an MRI, of course, and then clean out the cartilage, and then that's what you get. And this can help alleviate a lot of mechanical symptoms. Number 2. So you ask yourself, you lose articular cartilage, and then the next thing you have is subchondral bone. Where does the pain of arthritis come from? I always wondered that myself, because if you have articular cartilage, which has no pain fibers, and you have bone, the outside of hard bone, when you look at the outside of hard bone, there's no pain fibers on the outside of hard bone. There's pain fibers in the periosteum, but there's pain fibers inside the bone, but there's no pain fibers on the outside of the cortical bone. So where does arthritis pain come from? Well, it develops because essentially when you lose articular cartilage, you develop swelling inside the bone. So that swelling stirs up the proprioceptors and the nociceptors, which cause sensation back to your brain. That increase in pressure tells your brain that your bone is under pressure and is in pain. It sends signals back to your brain.
Question.
Oh yeah.
That white spot, earlier you showed it on the hip or something, and you said that that's where water was accumulating?
Right.
Is that what?
It's the same type of thing. Exactly.
And so what takes, if a person's not ready for surgery or whatever, what can they do to take the water away?
What can you do to take the water away? Well, what I mean by water is that there's swelling inside the bone. And why is there swelling? Because there's inflammation. There's been damage and insult to the bone. So in a sense, if you can take the water away, if you can take the pressure away, can you take the pain away? Well, that's a concept that I'm going to show in just a second. So here is an idea, and this does not apply to everybody. Don't go running to your doctors and telling them you want this done. Because once you have an MRI that shows this type of swelling, basically we can almost call it a subchondral fracture. Okay? It's a microscopic fracture which causes swelling to develop. All right? And that swelling is what causes pain. So if you have an MRI that looks like this, one of the things that you can do is actually, there's a new technique here called the subchondroplasty, which basically uses an X-ray device, and we put a needle inside the bone and we inject cement. And this is a natural cement that your body can absorb over time. So after you inject this, what happens is that it basically stabilizes that bone, which has a subchondral fracture, and then that bone cement eventually resorbs and remodels into normal bone. Now this is not for everybody. It's for people who, like I say, think about this once again. You lost the air in your tires, so what happened? You damaged the rim. You bruised the rim, okay? And that's essentially the explanation for how this technique can work. It's not a very common technique, but it's, it can help those people who have a relatively good knees, who have acute amount of swelling and basically subchondral fracture. Okay? Any questions about this? So let's talk a little bit about knee replacements. I had a video, but it's not really working. So I'm going to just show you a little bit about how a knee replacement works. So in essence, this is a little cartoon that shows what a typical knee replacement looks like. And if you have any specific questions about this one, please stop me. But in essence, when you have arthritis in the knee, you make a longitudinal incision in the skin, like so. And then essentially, somebody asked me, I don't want to get a knee replacement, I want resurfacing. Well, every knee replacement is a resurfacing operation. Okay? Every hip replacement is essentially a resurfacing operation, essentially. Okay? So what you're doing is you're making skim cuts in the bone. So you take a saw intraoperatively and you take skim cuts to the bone, like so, that are sized perfectly to implants that we size during surgery and also on x-rays before surgery. And then these implants are glued into position with methyl methacrylate glue. And the same is done with the kneecap as well. The kneecap is resurfaced, bad cartilage in the bone is removed, and a plastic component, polyethylene component, is glued back in position. Oops. Oops. Yeah. So that's what a regular knee replacement is. So regular knee replacements, basically we use metal and plastics, and they're glued onto the bone, okay? Sort of back to the idea of getting articular cartilage. Articular cartilage is neuropathic, no sensation. Metal and plastic, no sensations. That's what you're trying to recover. That's what you're trying to replace the damaged cartilage with, okay?
So if there is that white spot that you see and you do that, what do you do for the day?
You're getting rid of the white spot. Perfect. That's a good question. See, you know, honestly, what I've had is I've always wondered, why do some people with really bad arthritis not have any pain? But then once in a while you have somebody with very little arthritis have a lot of pain. So that brings me to an interesting idea that sort of dovetails into this idea. When you think about somebody who's had arthritis for a long, long, long time, their bones are as hard as a rock. It's almost like a river pebble. We call that eburnation. That bone becomes so hard that the bone underneath it doesn't experience any stress. You see what I'm saying? It's like a trampoline that's frozen so hard that when you jump on it, the pressure doesn't go underneath it. So, if you've had arthritis very slowly for a long, long time, sometimes the bone underneath doesn't experience a lot of stress, and therefore, you don't have a lot of pain. Okay? And that's also the reason why sometimes people with lateral-sided arthritis, so this is the medial side, but if you have arthritis on the outside of the knee, you have actually more pain than people who have arthritis on the inside of the knee. I didn't have any slides of this, but most people are slightly bow-legged. So most of the arthritis is on the medial side of the knee. 75% of people have arthritis on the medial side of the knee. So that bone on the inside, as you grow, becomes more dense. So when you develop arthritis, the pressure doesn't get transmitted into the trabecular bone as much. So the pressure fibers aren't affected as much, if that makes sense. But people who have arthritis on the lateral side have a lot more pain. 25% of people have valgus knees or knock knees. So that pressure gets transmitted because more effectively, and so those people you tend to have a little more pain than people who are a little bow-legged. Go ahead.
Procedure.
Yeah.
Can that be used for meniscus tear?
No, this is not for meniscus tear.
Okay.
Meniscus, yeah, this is underneath the bone.
Okay.
This is inside the bone, actually.
Okay, that's
So,
fine.
go ahead.
Are you saying the inside of the knee is more common to have?
75% of people have arthritis more on the medial side of the knee. So when I look at somebody who comes in with arthritis pain, most of the time, 75% of the time, the arthritis will be on the medial side. Okay? And also, when you think about it too, okay, this is a little tangent, but once again, why would that be? It's the meniscus, you see? Which side does the meniscus tear more on? The medial side or the lateral side? It's the medial side. The medial side, the meniscus is less mobile and therefore less resistant to shifting. So therefore, the medial meniscus tears more often. Therefore, people develop arthritis more on the medial side. Anything else? Go ahead.
Do you do the kind of knee surgery where you don't cut the muscle?
Oh, that is a different type of knee surgery. In essence, you're talking about, are you talking about the subvastus approach?
I'm not really sure.
Yeah.
exactly.
There's basically three different ways to do a knee replacement. You guys are asking really sophisticated questions. I don't have a model with this, but in essence, think about this. When you do this incision here, after you go through the skin, you're making an incision through the deep tendons, okay? So when you make the incision through the deep tendons, you can go straight across this way and go straight up the tendon. Or you can go slip this way, which is sort of along the muscle fibers. Or you can go underneath the muscle fibers and push everything out so you protect the entire extensor mechanism. That's a more difficult way to do things. It's not been proven to be any better, though. It's not actually been proven to be any better. That's sort of, I think most people, you know, there's things that are sort of, hot ideas when they come out, but they don't necessarily stand the test of time. So, anybody else? Okay, where was I? Okay, so that's basically the how a total knee replacement works. You have any questions about that? All right, so this is a partial knee replacement, and this is a total knee replacement. Partial knees can be done for people who have just one-sided arthritis, mainly on the medial side of the knee, okay? And this is a model of a total knee replacement. So here's a picture of a partial knee replacement. Here's an x-ray of a partial knee replacement. Here's a picture on an x-ray of a total knee replacement. And you can see here that there's glue. There's methyl methacrylate glue that holds the components together. I'm going to talk about a technique that doesn't use glue, so I just want to show you the x-ray. Go ahead. Yes, sir.
Once you have a total knee replacement, there's no arthritis.
Arthritis is gone.
That's right.
Yeah, exactly. Hmm?
No problem.
Yes.
Lastly, they used to say that the replacements lasted 10 years. Now you're shooting more towards 50 to 20 as long as you don't really heavy lifting.
The thing is that, and I'm going to talk about this in a second, but our goals of total knee replacement, total hip replacement are number one, pain-free function, but also longevity. And longevity is is basically everyone's holy grail. We're all trying to achieve that. So when you look at the old data, you say that most knee replacements last 15 to 20 years. That's on patients who are maybe more sedentary. First of all, lifespan's increasing, and everyone's much more active at 65, for instance, than we were 20 years ago at 65. You see, you're much more active than you were, when your parents or your grandparents were the same age you are now, right? So. And that's a goal that I'm going to talk a little bit about longevity, the factors that will help improve longevity in 1 second. Okay, let's talk about hips a little bit too. Now, hips are something I'm really interested in. That's because in the past, we just said, you come in with hip arthritis, you look at your x-ray, the next thing you get is a hip replacement, right? We didn't understand why people developed hip arthritis. And in the same way as a knee, the function of these structures, these soft tissue structures, such as the labrum that help distribute the force across the hip, the functions of osteophyte formation along the neck that cause impingement. There's ideas, which I didn't go into right now with my slides, but there's a thing called femoral acetabular impingement, which is it's basically pinching between the hip, the ball of the hip, and also the cup of the hip. That will determine whether or not you develop arthritis. So some of the newer procedures out there allow us to fix, with arthroscopy, damages to the labrum and development of bone spurs. Okay? Any questions about hip arthroscopy? Who's in? Yes, sir.
What is a bursa?
What's a bursa? Oh, okay. I don't have a video on that. The bursa is basically, you got bursas all over your body, in your kneecap, on your elbow, okay? But the hip bursa is a bursa that protects the tendon from the bone. So as you walk, when you flex your hip, the tendon goes in front of the wide part of the hip, and when you bring your hip back, it goes backwards. So it constantly flips back and forth. And sometimes that bursa can get really inflamed, and that's called bursitis. Yes, sir.
What causes it?
Inflammation of the bursa. Sometimes it's traumatic, sometimes it's lack of stretching, sometimes, there's a lot of causes for it. Yes, sir.
After several injections, the doctor then said, well, the only way to go now is through an operation, burst operation.
A bursa operation? Well, that's a newer operation. I didn't really talk about that here, but basically, there's two ways to do that. You make an incision, and you make a window in the bursa. I'm sorry, in the IT band, and you clean out the bursa so that no longer the bone is no longer rubbing against the tendon. Okay, so let's go on with the hip here. Anybody interested in hip arthroscopy? Does anyone have questions about hip arthroscopy? Because I could talk a long time about this too.
Just, how do you tell if that's what you need versus the hip replacement?
Yeah, that's a good question, actually. Because once you have arthritis, the cat's out of the bag. Okay? But there are precursors to arthritis, such as, let me show you over here. Here it is. There are precursors to hip arthritis, such as this femoral acetabular impingement idea. Okay, so there was a guy named Dr. Gans, okay? And I wasn't going to tell you the story, but this is I like telling stories so that you understand where we are, okay? So Dr. Gans was a very famous Swiss pelvic surgeon, and what he did was, when people had shallow hips, in other words, you had a very shallow acetabulum, so the ball wasn't covered, he would do an osteotomy and then change the position. He would bring the huge operation. Anyway, he'd shift the entire pelvis over so that you had more coverage to prevent arthritis developing, right? Because everyone has a shallow hip can develop arthritis, like, you know, like German Shepherds and, you know, things like that. So anyway, what he found is that some people had pain in their hip. Because what he found is that if you over-rotated, then you had too much coverage, and then the two components of the hip, bone, the ball, and the cup would bump against each other. So you call that femoral acetabular impingement, FAI. So if this is considered normal, if you have femoral acetabular impingement, there's three ways you could have it. One is you have a bump on the hip bone up here. Okay? So as you put your hip through a range of motion, this bump, we call that a cam lesion, will hit against the cup. And that'll cause damage to the cup. So what can you do with hip arthroscopy? You can go in there with a camera and you can shave this down. So there's a pincer impingement. Pincer is if the cup is too big. Okay? So as your hip goes through a range of motion, the ball here along the neck could bump into the acetabulum. That's called a pincer lesion. Most people have a little bit of both. That's called a mixed femoral acetabular impingement. So if you don't have any arthritis in your hip and you have an MRA or X-rays that show that there's damage to the labrum and then you have small osteophytes along the neck, you can actually get this done. That might preserve your hip and prevent you from getting a hip replacement early, or slow down at least the progression of hip arthritis.
How do you know which one you have?
You have to talk to your doctor. You got to get an X-ray, and sometimes you have to get an MRI. Sometimes, even with an MRI, you can't really see it. Sometimes you have to look inside, actually. Yes?
I'm an exercise person.
Mhm.
I have a hip replacement.
Mm-hmm.
It's been great. It's
Mhm.
lasted almost 15 years. Still works like a charm.
Mm-hmm.
But now my good hip is starting to hurt. Feels
Mhm.
like a pen poking up into my socket, just like the other one used to feel.
Uh-huh.
Are you saying that maybe I could move it over since it's
Oh,
just
you could,
starting?
just because you're starting, yeah, sometimes. I mean, it might take it might obviously take X-rays, and we might have to, take a look at it. But it's possible if you have no arthritis and you see the early precursors of arthritis developing. Like for instance, one of the things that doesn't work in this case, and I'm looking at you and I think you're pretty young. So when I see somebody with young who has arthritis at that age, there's only a couple things that can cause it. Skiffy is one, hip dislocation, AVN is another, or it could be dysplasia. If you have a shallow hip, this operation is not a good operation.
Well, I wasn't a candidate before.
No.
Uh,
You might,
That was a long time
it's
ago.
possible that your arthritis is too advanced, perhaps.
Oh, okay. Well, the other question I have is,
Mhm.
I've got the old
Mhm.
hip replacement.
Mhm.
If I have to get this one replaced, I know there's newer procedures, smaller scar.
Yeah, smaller incisions.
Is that gonna make a difference that I have two different kinds of hip replacement?
Oh, no, no,
It's not gonna make a
no.
difference.
You mean in terms of old implants versus newer implants? Not really. It's like, and they're all very, very similar now. Like Toyota, Honda, they're very similar. Okay, so
Are there different choices?
there are different choices.
In other words, you showed an example for the knee, or are there multiple?
There are multiple different implants. And in the old days when you had a car, when you bought a car, like, I don't even know, like in the 70s, when you bought a Saab, the ignition was in the bottom. And when your cars were first made, the gas was, in some vehicles, the gas was on the left side instead of the right. Now, all the cars, you can close your eyes and almost get into a car and you can almost drive it, right? That's because all these implants had disparate ideas when they first came in. They thought, one company thought this would work, one company thought this would work. And now they're all sort of coming to the center, and pretty much all the companies' implants are very similar now.
Does your practice stick with a certain?
We stick pretty much with Osteonics,
Okay.
Stryker. They're a tried and true company, and they don't do a lot of crazy things. They don't go off on a lot of tangents. Some companies find the next wave and they just really jump on it. And
Are there certain models that are more oriented towards certain disease than others? Or
no, not really. No,
Okay.
the procedures are all pretty much the same. Like for instance, we talked about resurfacing of the hip a while ago. Resurfacing of the hip was very popular for a while, but not too many people do it anymore because that's, like for instance, metal on metal hips. We all know about metal on metal hips, and our experience with metal on metal hips has not been very good. And resurfacing is sort of a metal on metal hip, and that's why we sort of, we don't do metal on metal hips anymore. Okay. Yes, sir.
Dr. Sohn, I'm a veteran, and I went up to the Veterans Administration about 6 years ago for a knee replacement consult, and that surgeon told me in Detroit that I was not a good candidate for a knee replacement because I had 4 cases of MRSA within 2 years prior to the knee replacement. But this was like in 2011. It's 2018 now, is the fact that I had MRSA 6 or 7 years ago going to stop me from having a knee replacement?
It depends on where your MRSA was. That's a very specific question. I think it really depends on where your MRSA was. If it's in the knee, it makes it very difficult to treat.
There was one right here, it's up on my stomach.
Yeah. I mean, if it's on the skin, that's okay. But
Oh,
if
it's
it
on
was
the skin.
if it was deep infection, that's one of the things we didn't talk about, and that is one of the risks of having joint replacement is infection. Once you get an infection in your joint, it's very difficult to eradicate. It's a disaster. So, okay. So let me talk a little bit about hips here, okay?
Right.
Okay.
Thank you, doctor.
So hips, the way you do a hip replacement is there's essentially three ways to do a hip replacement. You make an incision on the outside of the hip, and you either pop your hip backwards, which is a posterior approach, or you pop your hip forward, okay? We shave out the bad part of the bone, like so, and then we'll clean out the center, and then you put a new implant in like this. You put a new ball on top. In some cases it's metal, in some cases it's ceramic. And then we shave out the pelvis, the cup part, and then we implant a new metal component onto the cup part. And then there's a plastic piece that goes in. Now hips are a little different from knees because for the most part we use cement-less equipment. So most of the time we don't use cement on hips. And I'm going to talk about this in a second, but in the old days, like in the 70s and 80s, they used cement on hips. Now we don't anymore. So that's a big advance. The materials have gotten better, and our results with cementless hips are really good.
Does the bone grow into the implant?
Yeah, exactly. The bone grows into the implant. So I always say, like, people might get mad if I say this, but it's like when you put in a basketball post or a post in your backyard, if you use cement, that cement goes into the ground and holds the post up, right? But over time, it could loosen, right? If you put a tree in there, which grows into the dirt, then it has a, it's a more stable structure. This is a living construct. What we're trying to do is have the bone react to the surface of the metal so that it grows into the metal and you have a biologic construct. And if you have a good biologic construct, you have fixation for life.
How long does it take to bone to grow to that?
It takes, well, you know, that's a tough question to answer. Like, usually about 6 weeks or so, at least 6 weeks. Bone grows at a pretty slow rate, but about 6 weeks. You'll start seeing some changes. Now, it takes a while for the bone to fully remodel, but you start seeing some changes at about 6 weeks. Okay, so any questions about hip replacements? Yes?
You cut the muscle like you said,
Well,
knee?
the thing about hip replacements, and you know, you're gonna have a lot of questions about hip replacements. When you go through the back, you split some muscle and you cut some very small, short rotators. And when you go through the front, you stretch out a lot of muscle. You may not necessarily cut them, but you damage some muscle. And you actually go through the capsule and you go through ligaments and stuff. But do you really cut muscle? No, not through the front, you don't.
I'm not familiar with muscle repair, but do you stitch the muscles or do they regrow?
We repair the
How does that
muscles.
work?
Yeah, we repair the muscles. Mhm.
And how long does it take before you're moving and walking and,
Oh, you're walking the same day.
are you?
Yeah, a lot of people go home. You can go home the same day almost with a hip replacement. Yes?
I have a question, and I wondered, if you have like full-blown osteoporosis, are you not a candidate for any of these options as far as replacement because
No,
bone wouldn't be?
no, not exactly. Osteoporosis is not as a contraindication necessarily. You just have to be more careful, you know. You may not be a candidate for like a press fit component, but you know, it doesn't preclude you from getting a joint replacement. Yes?
When they talk about this new hip replacement surgery that doesn't have as big a scar, what are they talking about?
Oh, you mean minimally invasive surgery?
Yeah.
Yeah, we use smaller and smaller scars, and I'm just going to talk about navigation, how that helps us to make smaller scars. But we're all trying to do the least amount of damage, least amount of surgery and trauma to the body.
What are we talking in inches?
Usually about, it depends how big you are, but most,
Look at me, I'm this side.
most incisions are about 5-6 inches long. If you're bigger, it takes a bigger incision. Okay. I'm sorry, anybody? Yes?
My husband had both hips replaced, probably 3 years apart.
Hmm?
One by a father, and then he retired, and then the other one by the son. And this second one pops out all the time.
I'm going to talk about that in a second.
Is there
I'm going to
any-
talk about that in a second, okay?
Okay.
Watch this. So this is an x-ray of the total hip replacement. Any questions on this x-ray? Okay. So what are the goals of joint replacement? You want pain relief and you want longevity. So what are the components of longevity? Well, the annual failure rate for a hip and knee replacement is about 0.5 to 1% per year. So, you know, 10 years, there's a 90 to 95% chance of survival. In 20 years, it drops to about 80 to 85%. And as the population continues to age, and also our activity levels increase, it gets more, this is quite a challenge. So I call it the holy grail of orthopedics. So this is an alignment of a perfectly normal knee. And why is alignment so important? So what I want to talk about is a little bit about how we try to get perfect alignment and how alignment is so important. And number two, I want to talk about the materials, okay? The alignment is very, very important. Mechanical alignment is very important. What we want to try to do is make sure that if you had a weight attached to a string that goes from your hip all the way down to your ankle, that it goes right down the middle of your knee. You see that? So when you get a knee replacement, you want it to look just like this. So you don't have, you know, undue stress on one side of the component versus another. So you don't want the knee to flip. You don't want cantilever stress on one side of the knee or the other. So alignment is very, very important. So bad alignment like so, you can see that this is in varus. We call this varus. You're bow-legged on this one, okay? So if you have bad alignment, it can lead to early failure, okay? It could lead to early failure and also loosening. So malalignment of the hip, why is that important? Well, alignment is also very important in the hip because what we do is we spend a lot of time looking at your x-rays. In this case, we do a lot of templating, and we put the implant in perfectly the way we want, the way we planned it, okay? If you don't put it in a way that, in the ideal position, then it could lead to undue wear, which can lead to loosening. See how this piece is loose now? And this person has to get a repeat operation. Also, in the hip, you can have dislocation. Why do you have dislocation? Because if the implants aren't in perfectly, then the way it contacts each other, and you put your hip in a funny position, it could pop out of place. So little changes in degrees. For instance, when you look at something, can you tell that's perfectly zero? But if you go back and forth, it's very hard to see with your eyes how much 5 degrees and 10 degrees is. And inside, when you're doing an operation, things could shift. So it's very difficult to know exactly how things are going in. But sometimes when implants aren't in the perfect position, then it could lead to things like dislocation. That's one of the reasons, not the only reason, but that's one of the reasons, okay? So, everyone understand how important alignment is in the hip and knee. Yes?
Does robotics help in the precision?
Robotics can help, but I'm going to touch on the robotics too. But, so everyone understand the importance of alignment. So what we're trying to do is create as much surface area so that the stress, once again, stress is equal to force divided by area. We want to increase the amount of area that's in articulation to decrease the amount of contact stress. All right. So one of the things that we want to talk about is we want to talk about computer navigation, which is a lot like robotics, but there's a slight difference. Computer navigation is what we use at our hospital. We've used it for over 10 years now. And what it basically is like is GPS for surgery. As you do smaller and smaller, minimally invasive surgeries, you're not looking at the whole wound. You're not looking at all the entire skeleton. What you're doing is you're just seeing very small parts of the body. So the computer navigation allows us to see how everything is positioned in real time in 3 dimensions. So it's like GPS. You never get lost when you use computer navigation. Also, like I told you, you could be 5-10 degrees off easily. And sometimes when some people have hip replacements, sometimes one leg's longer than the other, and you don't even know until afterwards. But what we do with navigation helps us make sure that we can reproduce the surgery to a very, very fine degree, very high tolerances, and also we get a significant amount of accuracy, okay? And the point of all this is that you have early satisfaction, you can get up and move right away, and also you have long-term benefits. In other words, you get longevity because of the better alignment, okay? So implant alignment is an important factor that may reduce joint wear and extend the life of the implants. So this is sort of what it looks like. It helps us to align the jigs that we use during surgery to make sure that, you know, it's just like carpentry, you want to measure, 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 and then when you make the cut, you know it's perfect. So this is how it sort of works. What we use computer navigation, which is an infrared camera system that sort of sends infrared signal throughout the operating room, and then we put implants on the appropriate joint, the knee or the hip. And then what we do is we use the computer gun like this to mark different landmarks. And then the computer understands where you are in space. And so when you put the next jig on, when you use the saw, you know exactly where you're making the cuts, okay? In this particular case, with our computer navigation, you don't need CT scans, you don't need the extra cost of MRIs. It provides real-time guidance. So if you're doing something you think, something's a little wrong, then you can back up, put your points, pick out your landmarks once again, and then recheck. So it allows you do real-time checking. This is robotic surgery, one type of robotic surgery. Now this company came out, Mako came out, actually I'm not quite sure when it came out, but it was bought by Stryker about 2 years ago, I think, 2-3 years ago. And what this is similar to computer navigation, but it requires CT scans, and what you do is you place landmarks, and then what this thing does is that it has an arm that comes out and has a saw that allows you to position and helps make sure you don't make mistakes. But in a sense, it's not, when it first came out, it's hard to explain, but when it first came out, it was good for total hip replacements, and also you used it for partial knee replacements. So this is a partial knee, and basically what it did was there was a milling device. So you got a CT scan, and then you put the landmarks in, and then this milling device, which is a little tiny drill that you use to shave away bone. And so if the surgeon made a mistake and you went too deep, it would turn it off. So it would help you mill and shave down an area. I thought it was a little overkill, and I didn't think it was as accurate as making a saw cut. Saw cut, using saw cuts, gives you a flatter, smoother plane than using a mill, you see? Now they came out with a saw, okay? So they're doing, in the past they were only able to use it for partial knee replacements. Now they've started using it for total knee replacements. But is it any more accurate? No. Does it rely on information you get from a CT scan? Yes. So in a sense, this robotics, you basically, it's like hand holding for the surgeon essentially. The surgeon holds it and pushes it, the instrument around, but it doesn't necessarily make it any more accurate than computer navigation. The other thing that we have is custom-made surgical instruments. So this is a technique in which you get an MRI of someone's knee. Let's talk about knees, for instance, for a second. So you get an MRI of someone's knee, and it shows all the bumps and dimples on the bone, okay? And you plan out with this computer software how much bone you want to resect. And then you get this 3D printed model. And then this thing is a cutting jig that comes in with it. So it attaches directly on the bone to every contour and every dimple on the bone so that it's very nice and rigid there. Then you fire pins in there and then you start your operation. So this is a these are custom-made cutting blocks for implants to be placed.
You make the implants?
We don't make the implants. What we do is you get the MRIs, and then the company makes the 3D print these implants and the cutting guides.
Okay.
So it speeds up the operation a little bit and makes it accurate, more accurate in a sense, because you know exactly where to make the cuts. Once again, this hasn't been proven to be any better than computer navigation.
Is that what you use then?
No, we don't do this. We use computer navigation.
Okay.
Okay. This technique is actually not as accurate as computer navigation because once these are made, you really can't change them too much, you see? Okay. And also, if you put it on the wrong dimple, you can be wrong. You know, there's human error involved in these things a little bit, to some degree, okay? I do use something like this in the shoulder, though. In the shoulder, if I do a shoulder replacement, I get a CT scan of your shoulder, I get a 3D model of your shoulder, and I place an implant that's 3D printed onto the shoulder, and then start the operation that way. It gives me a much more reproducible way of doing the shoulder replacements. Okay. Yes?
First of all, we've been told that if you have a steroid injection, you cannot have, or they don't want to do surgery for 6 months.
There's a risk of getting a steroid injection. If you get a steroid injection, what do steroids do? Steroids are an anti-inflammatory, okay? What's inflammation? Inflammation is healing, but also inflammation is what your body uses to fight infection. So in a sense, it diminishes your ability to fight infection. So if you were to get a steroid injection and you get a joint replacement, has the potential to increase the rates of infection. It's been shown in the hip but it's a small increase. It's not a huge increase. And some people lay down laws that say 6 months, but I don't really do that. I don't think it makes that much of a difference.
Are you the only one in your practice that does this with the computer navigation?
No, we all do it. Almost all of us do it. Yeah. I think everyone but one person does it. Yeah. Mm-hmm. Yes, sir.
You mentioned different length legs. I had some physical therapy for my back, and the therapist indicated that one leg's longer than the other, and sort of related that to my back. But I'm wondering now if that could be attributed to my arthritis.
It's possible. Yeah, absolutely. Absolutely. I operated on somebody yesterday who had a significant difference in one leg because one joint was so collapsed, it was about an almost 2 centimeter difference. So you can make that up in many ways. You can make that up in the hip. It's in the hip, it's easy to make up.
So you do compensate for that?
Oh, sure, we try to, yeah.
Okay.
Okay, so these are the custom guides, okay? Any questions about that? All right. So we talked about alignment. How do we get alignment? Computer navigation is one way. Robotic surgery is another way. Custom-made implants is another way. So you make sure that the hip and knee are in the perfect positions when you do the operation, after the operation. The other way that there's been advances are materials, okay? So there's a school of thought that says that the reason why implants fail over a long period of time is that the little pieces of plastic that the metal rubs on, so all joints have this surface where the metal rubs against the plastic. And when you get an electron microscope and you look at a metal, even the most smoothest mirror surface has rough edges to it. So over time, when that articulation, you put thousands of millions of cycles through it, you have little plastic wear debris, okay? That wear debris causes an inflammatory reaction, which causes your body to react to that foreign body, which causes loosening of the components. So some companies say, well, let's defeat that problem by making smoother metals. So there's companies out there that use ceramics. So in the hip, we do that. In the hip, you have an articulation between the ball and the cup. The cup is made out of plastic, and the ball is usually made out of metal. But one of the things that we can do is we can change this over to a ceramic, okay? And if you think about a ceramic's a wettable, just like a dish. You can water beads on it. And also, it is much smoother than a metal. So over time, you'll have less wear debris and less chance of developing this inflammatory response, which causes loosening. The other thing that's new is the other thing that's new is the plastic. And this is not a brand new thing, but the plastics have become more and more strong so that there's less wear. So the metals have become smoother, and also we can use ceramics, but also the plastics have become harder. So no longer do they wear as fast as they did in the past, and so you're not getting as much wear debris, so you won't get some of that loosening that develops, okay? And the third thing is we talked about cemented knees, and we talked about the fact that in hips, we don't usually use cement anymore, and we use porous ingrowth, and we have implants that grow into, the bone grows into the implant through the use of special coatings on the metals, okay? So the newest thing is this thing, porous metal, so I'll talk about that for a second, okay? So ceramics, you have metals here. In this particular case, this is an oxinium knee, which is a metal, but what they do is they put it in a blast furnace and they put a lot of oxygen in there and they create a ceramic covering over it so that it becomes a smoother surface, thereby decreasing wear particles. So most knees out there are metal and plastic, and so the interface is metal, you have cement, and then you have bone. So the cement holds the metal onto the bone. And over time, they can loosen, okay? Because this is, once you have fixation, the strongest fixation is right when you put it in, right? Over time, it can tend to loosen, okay? And also, you can have that aseptic loosening I told you about, where the body reacts to the wear particles. But the other way of doing a knee replacement is to use metal that has a special coating like this, has a porous coating that you put directly onto the bone, and the bone slowly grows into it. Like I said, we do that in the hips all the time. Hips, in the past, we used to use cement. Now we have special coatings that allow the bone to grow into it. So the newest things that are out there are metals such as this. This metal is made up of it's called trabecular metal, okay? And this thing is like a loofah stone. Essentially, it's very, very porous, okay? So this thing is and all companies are beginning to use materials like this. They're using 3D printing do you guys understand what 3D printing is, by the way? I kept on using it, I said that a couple times, but now you can use 3D printing to make this stuff. These plastic things, and that's plastic 3D printing, okay? Some of you guys probably did like machine shop work, so you understand all this even better than I do. But this is plastics, but now you're beginning to use 3D printing to print metals. So the metals have an incredibly high porosity so that it allows the body to grow into it. So these are the newer technologies out there. Now what's the benefit of that? You're trying to get biological fixation. You're trying to get the bone to grow into the metal, okay? Now this has not been proven, so don't run to your doctor and say, this is what I want. This has not yet been proven, okay? In fact, when you look at studies that show people who have had press-fit knees, and that's what, this stuff is called, using porous metals, press-fit knees that you don't use cement, or versus cemented knees, the longevity is about the same, okay? So about 15, 20 years. But when you look at the numbers very closely, you'll see that the people who got the press-fit knees were younger. So that's sort of like the Holy Grail. You have younger patients who are much more active, theoretically, that can have the same longevity as a retiree, you see? So, any questions? All right. I really like, so in summary, we talked about ligaments. Ligaments are there to stabilize the joints so that it protects the meniscus or the labrum in the hip, and which eventually protects the articular cartilage. The articular cartilage is neuropathic, doesn't feel anything. So our job as surgeons is that when you damage the articular cartilage, we go in there and put in another neuropathic device, which in this case is metal and plastic. So I talked about the importance of alignment, the use of computers and patient-specific guides. We talked about materials, ceramics and plastics and porous metals and 3D printed metals. Thank you. Go ahead.
I hear people who have had knee replacements say that they can't, bend down on their knees. Can you talk about that a little bit?
Yeah, we don't exactly know why that is, okay? And some of the people, there are doctors out there that feel that when you look at the knee, there's a thing down here called a fat pad, okay? First of all, you made an incision right in front of the knee. So if the incision's right where you're kneeling, you can obviously see that that would be a source of pain. But also some people think that the fat pad back here, which acts as a cushion, okay, that's the culprit. So a lot of people, when we do the operation, just to make things make things more visible and easily done, you flip the kneecap over and you take the entire fat pad off. I've been preserving as much of the fat pad as possible to allow for that cushion to be there. Now, does that mean that, if you keep the fat pad, you don't have as much problems kneeling? Not exactly, but that's one way of dealing with that problem. Some of my patients have no problems kneeling, and some of them still have problems kneeling. I don't think there's any studies out there that say that this is the culprit and you got to do this in order for your patients to kneel. Yes, sir.
What causes the clicking in hips or knees?
After a knee replacement or before?
Before.
Okay. Well, there's a lot of causes, but one of the causes can be, ligaments riding over an irregular surface is number one. Number two, your body creates little vacuums because there's water inside your joints. So as it rides over an irregular surface, sometimes a vacuum can form and that vacuum pops. That's the popping noises you feel.
Nothing to do necessarily with alignment.
Alignment? No, it's not an alignment issue.
It's
As long as there's not pain associated with it, it shouldn't be a problem. Now, if there's pain associated with it, if you have something floating around your knee or hip, like a loose body, that can create popping, but that would usually be associated with pain. Yes, ma'am.
What's the deciding factor between doing partial versus complete?
Right. Partial knee replacements are a very useful adjunct for us, okay? Recently, some studies have come out saying that they're not as good in terms of long-term pain relief and longevity as a total knee replacement. But the criteria for getting a partial knee replacement is, number one, you have to have osteoarthritis. You can't have rheumatoid arthritis. Number two, you have to have an intact ACL. Number three, you have to have no arthritis on the outside of the knee. Number four, you have to have very little arthritis on the kneecap. And if most of your arthritis is on the medial side, now they do have partial knees for the kneecap, and they do have partial knees for the outside of the knee, but all in all, for unicompartmental knee on the medial side, you have to fulfill those conditions. And then you can get a partial knee. Now, what's the benefit of a partial knee? When we talked a little bit about alignment, okay? And the thing is that when you have a partial knee, you can recreate your normal alignment, okay? When you do a total knee, we're not making your knee exactly the same. We're not putting in the knees in exactly the same way that God made you. It's a little different. And the reason is because we have constraints, such as the interface, like I talked about, that it could loosen up if you don't make it perfect. Now, not too many people are perfectly straight up and down. And the components, I mean, your alignment, there's one of the slides that showed that the tibia even is, on an average person, is tilted 3 degrees. But if you put a total knee in 3 degrees of a malalignment, it'll fall apart. It could much earlier. So what we have to do is we have to compromise with the materials we have, and when we put it in a knee, we can't put it in normal alignment. With a partial knee, you're putting it into normal alignment essentially, okay? Because you're constrained by the ACL and you're constrained by the lateral compartment. That's why people with partial knees probably feel a little bit better. They recover a little quicker, okay? And they have better range of motion, okay? But they don't have as much arthritis to begin with, too. So, okay, yes, sir.
I understand the American Dental Association now suggests you don't need to take antibiotics.
Yeah, after
procedures, when you have hip replacement and stuff like that. What are your thoughts?
The recommendation is that you usually take antibiotics for about 3 years, okay? But I tell my patients, what are the risks versus the benefits? If you get a knee infection or a hip infection, and I have had people who have had dental work done get infections, okay? And obviously in my history of slightly less than 1,000, that hasn't happened to me that many times. But in my experience, the benefits of taking antibiotics versus the risk, what's the risk of taking an antibiotic, 2-3 antibiotic doses? It's not that high. But the risks can be pretty high, so I tell my patients to keep taking it. Yes?
What's your suggestion as far as when do you decide that you need to go have the x-ray or MRI? When you have mild pain, or do you wait till it gets worse, or do you wait to do the self-treatment as far as...
You do the self-treatment first. Do the self-treatment first. You exercise.
How long do you do that? For 6 months, a year, until it gets so bad you can't stand it?
No, I wouldn't wait that long, but I mean, I think if you do a good 6 weeks to 3 months of self-treatment, depending on how bad your symptoms are, everyone has different levels of pain tolerance. So if you can tolerate it, it doesn't bother you too much, take anti-inflammatory medications, do all the things we talked about in terms of conservative management. And if that doesn't work, it's worthwhile getting an x-ray. Now, is there something that you're going to miss and you're going to say, oh my God, if you came in earlier, we'd really solve this arthritis problem? I don't think so. Yes, ma'am.
Would you address the importance of physical therapy for any of these?
Yeah, so going back to, with a knee replacement, there's usually a lot of physical therapy involved because the knee just tends to get stiff. So you're talking about after surgery, After surgery, there's a lot of physical therapy, sometimes between a month to about 3 months sometimes. Okay? You got to regain your range of motion because the knee is not a perfect hinge joint. Okay, so it relies on ligaments on the outside. It relies, and it's not a perfect hinge. There's a screw-in mechanism. It tends to. It's not a hinge in the sense that it also sort of spins too. Whereas a hip is a pretty good ball and knuckle joint. So hips don't usually need as much physical therapy. So hips usually maybe a couple weeks of therapy, a month of therapy maybe. Yes, sir.
If you're told you need two total knee replacements, the longer you wait, does it make it any worse?
Oh, the one thing that you want to avoid is sometimes, I didn't show any pictures of this, but when you have a lot of arthritis, sometimes your body creates cysts, okay? So if you have a big cyst sitting around, that's the only time when I say, well, you probably should do it earlier than later. Because if you have developed cysts in the bone, then it weakens the bone. So I have to do bone grafting on that site. So if your cyst in the hips becomes the size of a nickel or a quarter, you should probably think about doing sooner than later. Yes?
Is there a chance that if you do need a double knee surgery, that you do both of them at the same time?
Oh yeah, sure. If you're healthy enough, usually my cutoff's about 65, but...
I'm under that.
Yes?
If you have pain in your knee and you don't get it fixed, can you damage your hip?
Well, anecdotally, sort of yes. Like for instance, if you have hip arthritis and you really shift your pelvis in order to walk, can you cause damage to your spine? Yes. Now, if your knee is really arthritic, does it cause more stress on your hips? Conceivably, yes, but I think probably logically yes, but I can't tell you as a matter. I don't have any proof for that. Yes, sir.
When you say that exercise can help to prevent some of these items, are you talking just like overall general exercise? You go to
Flexibility exercises, strength exercises. It's been shown that that if you can increase the strength of your quads. I mean, you think about it. Your quadriceps muscle not only is it from locomotion and strength, but it's actually the shock absorbers of your body. So developing quadriceps strength is very important and cushioning when you walk and run.